Welcome to Unit 4, Patient Intake and Vital Signs. Finally, we're getting into some fun stuff for this course. So in this unit, we're going to talk about the different vital signs as well as anthropometric measurements and the entire process of patient intake, which is really primarily what medical assistants do. So patient intake is like rooming patients, screening, collection of medical history, and then vital signs include temperature, pulse, respiration, blood pressure. Anthropometric measurements include height, weight, BMI. There's also a little bit about pediatrics in this unit. So we'll get started. This is just a list of key terms and definitions that you can see right here on one page. We'll be going over some of these as I go through these slides, but here they are on one page just to kind of help you when you're studying. So again, in this unit, we'll have patient intake, vital signs, anthropometric measurements, and some pediatric considerations when it comes to vital signs. I am going to expect you to memorize all of the adult normal ranges for these vital signs, but I do want, but not pediatrics, but I do want you to be aware that they are different and how they are different based off a person's age. Okay, so let's talk about why vital signs are important. There is a thing that we say all the time: vital signs are vital, which sounds really cheesy, but it just tells you how important they are. So previously on those definition page, one of those was homeostasis. And so what vital signs are looking for is if your body is in homeostasis. And just what that means is that everything's working the way it's supposed to in your body. And if it's not, then we'll be able to determine what's not working correctly based off vital signs. There are 4 main vital signs that we'll go over in this unit: temperature, pulse, respirations, and blood pressure. We'll also talk about some other assessment things that you could potentially do to determine if somebody is in homeostasis. Some of the reasons why the vital signs may be abnormal. It could be infection, illness, medical conditions, and we'll kind of talk about what those are based off the different vital signs. Okay, so as we are going through this and we're talking about the patient intake and then to vital signs, the very first step is to ensuring patient safety. And some of the ways we do that is by proper patient identification. The Joint Commission requires this as part of their patient safety. And we usually do that by having 2 identifiers. Commonly, we use name and date of birth, and it's really important that the patient states their name and date of birth, not that you ask them, is this your name and date of birth? Don't say their name. Have them say it to you, just to make sure. There are some other identifiers that you can use. You can use address, picture ID. There's a list of other things that you could potentially use to identify, but that's really important. That's the first safety step, is identifying the patient. Other things: infection control, making sure that you are washing your hands, using PPE, following all of your infection control safety techniques. Medications: when we get to medication administration, we'll talk about the 5 rights. For any potential injuries in the environment, that could be any type of hazards, whether that be like electrical, fire, even if there's something that for a fall, we want to make sure that we are aware of that and preventing any patient safety issues. So for instance, if you see water on the floor, you don't just walk away and leave it there for a patient to fall on. You make sure that you stay there, let somebody know, put up signs, clean up the spill, etc. And then, of course, communication safety, making sure that there are no misunderstandings when you're communicating with patients. that they understand, and then they provide feedback so you know that they understand. Okay, so as we go through the patient intake process, we typically call this rooming patients or interviewing patients. So as the medical assistant, you would be putting the patient in the room, essentially, and then getting their information to put in the electronic record before they see the provider. Okay. So after we identify the patient, we make sure it's our correct patient, we pull up the correct chart, then we speak to the patient regarding what they're there for. That is called the chief complaint. We use open-ended questions when we ask about the chief complaint. So we may say something like, "What brings you in today?" So that we could get that subjective information in their own words about why they're there. Every time you see a new patient, you update their medication record, and that's called medication reconciliation. We want to make sure that we have the list of their medications on the chart and also how they're taking it. I will just say be careful about if you already have medications listed on the chart. Don't just ask if are you taking anything new, because oftentimes patients don't know what you have on the chart, so they'll just say no. So make sure you go through each medication and ask them if that's correct. Hopefully they brought a list with them or the actual bottles to go by, because oftentimes they don't know the names of the medications. And then you also want to make sure that they're taking it the way it's prescribed, because sometimes when you ask, so you're taking this medication once daily, they'll say something like, "Oh no, I just take it every other day. I didn't like it every day. It made me feel dizzy," or something. So you would want to document how they're actually taking it, because that can make a difference with what the provider does. We also want to make sure we document over-the-counter medications and any type of supplements or herbal remedies, because some of those do interfere or interact with medications, and we want the provider to be aware of that before they prescribe anything. Allergy review. I know that seems silly that you would review that every time the patient comes in. However, they may have forgotten to mention an allergy previously, or the person before you just didn't document everything, or they have developed a new allergy. So it's just important to say, "I see you're allergic to this, this, this. Is that all? Is that correct?" And just make sure you're on the same page. You would include, of course, medications. I always like to say, "Are you allergic to any medications or food?" Because if you say, "Are you allergic to anything?" they typically go with, "I'm allergic to grass or pollen," or you can add those things, of course, but our primary reason for asking that are medications and foods. And then, of course, latex is a big one. And next, you would ask about their medical history. So, in other words, any previous conditions, chronic diseases, surgeries. I typically say, "Have you ever been diagnosed with anything in the past?" And they go through that. "Have you ever had any surgeries?" Sometimes if you ask that first, they'll say no, and then you get to medications, and then they'll tell you they're taking this medicine, this medicine, and this medicine, and then you'll have to go back and add that in. So they're taking a blood pressure medicine. Okay, are you taking that for high blood pressure? So you'll have to go back in and add hypertension, which is why I always recommend going through medications first, so you'll have a little bit of an idea of what type of medical history they may have. And then family history, I typically say specifically, "Do you have any family medical history, your mom, dad, brother, sister, or children?" Because if not, they'll try to tell you about their second cousin, and and those don't really significantly increase their risk for anything that's genetic or through family. So I usually say mom, dad, brother, sister, children. And then social history is important. We do need to make sure that we are documenting those things, especially for some of our meaningful use records. Social history is anything related to the social environment. So that can be their occupation, what kind of job they do. Some of that can affect their health. Uh, Smoking, tobacco smoking or vaping, alcohol, drug use, recreational drug use. If you ask about smoking, alcohol, and drug use, we always ask how much, how often, and for how long. So, how many packs do you smoke? How long have you smoked? That kind of thing. Living situation, if they are married in a committed relationship, etc. Um, Diet, exercise, stress levels, all of those things can affect their health. So we want to make sure we're getting that information in the chart. Again, here are some of the screenings. Tobacco cessation screening, that's one of the things we ask about tobacco use. And when we ask about tobacco use, we ask, are they interested in quitting and or trying to quit? Because there are lots of um, things out there that can help them and that we can provide for them. Same thing with alcohol. If they do significantly drink a lot of alcohol, you can do the questionnaire to see if that's problematic. HIV screening based off the way their questions are answered. Mini mental state exam is a dementia screening. Anxiety and depression, those are called, they're different forms, PHQ-9, PHQ-2, G87, just again, depending on the answers that the patient is providing, whether or not we perform certain screenings, or sometimes based off their age. So, like a depression screening is typically required for patients of Medicare age that's over 65, because depression is real common in that age group. And so there is a screening that has to be done. If they are I hate to say reproductive age, but typically like uh, 12 to 51, that obviously can change. That's just a age range. But anyone who's in the age range of having a period, we always ask about their last menstrual period. Even if it's not related to what brings them in, we have to have that for patient safety, because that could detect any potential pregnancies, reduce risk during medication administration or medical procedures, because you do have to, there are certain ones that you can't potentially be pregnant when you take. It also tells about reproductive health, any hormonal imbalances, helps with treatment planning and decisions, depending again on what the patient is there for. When we ask about the last menstrual period, you want to be specific and say the first day of your last menstrual period. Because if you ask, when was your last menstrual period, oftentimes they'll tell you the last day, and that does not offer the correct timing. So we want the first day of their most recent period. And then, especially if you're working in women's health or in an OBGYN clinic, you'll want to ask about cycle regularity. Is it regular, irregular? About how many days does it last? Uh, I mean, you can get more specific if you're working in women's health and they want more of that, especially if they come in complaining about things related to their menstrual cycle. Pain assessment, if they come in with their chief complaint related to pain, you absolutely want to get a pain level. Depending on their age or what's going on, is how we would get this assessment. So you can observe pain. So if they're grimacing, holding the area, clutching, crying, those kind of things, that would be an objective assessment. Like you can see that. And then, of course, there's the pain assessment tools. Typically, if they're an adult, and they can understand 0 to 10. We ask on a 0 to 10 scale. We typically say something like 0 being no pain at all, 10 being the worst possible. Give me a number. You can have a visual scale, especially like for children. We can use the Wong-Baker, the FACES scale for children. When we are assessing pain, if that's what they're coming in for, we get a number, obviously, but we can use the PQRST pain assessment. So P is provoke, so what causes the pain or what makes it better. Q is quality, how does it feel? Is it sharp? Is it dull? Is it achy? Those are some terminology. Radiation, does it spread to other areas? Do you feel it somewhere else? Severity, that's on that 0 to 10 scale. And then timing, when did it start? Is it constant or is it intermittent, meaning does it come and go? Okay, so as we are getting ready to talk about the assessment and vital signs and those things, let's talk about what we do um, before the patient even gets there and preparing the exam room. So, you of course clean and disinfect all surfaces, make sure that all equipment is stocked. If you know the patient's coming in for something specific, you want to make sure that specific equipment is in the room. Make sure things that need to be charged are charged. There's lighting. There should be some way to wash hands. Typically, rooms have a sink or hand sanitizer. Somewhere there are gloves or other types of PPE. And then, of course, proper waste material. Proper waste containers to put any used equipment or trash in. Patient positioning. If you are assisting the provider with an examination or you're preparing the patient for an examination, these are some of the positions. We'll actually talk about this more even in the next unit, but here are some of the terms that you may see when it comes to positioning. Supine is probably the most common. That's the patient laying flat on their back. That's used for abdominal exams, breast exams, any heart exams. They're laying flat on their back. Prone position is the patient lays face down with their head turned to the side. Obviously, we don't have their head or their nose into the bed, so their head is turned to the side. And that's for back exams or even injections. Fowler's position, that can be what we call semi-Fowler's, which is about 45 degrees. The head of the bed is elevated 45 degrees, or high Fowler's, where the head of the bed is elevated 90 degrees, so they're sitting straight up. And that's for things like respiratory assessments, feeding, upper body exams, neck, throat exams. Lithotomy position is the routine position used for gynecology. That is when the patient is lying on their back, but their feet are in stirrups. So pelvic exams, pap smears, that kind of thing. Sims position is the patient on their left side with their right knee drawn up. And that is typically for rectal exams, enemas, that type of thing. Knee chest position is just what it says it is. The patient kneels with their chest and patient kneels with their knees up to their chest. So that's, again, for like rectal procedures and exams. I did also want to say there's a little note here about always ensuring patient comfort, privacy, and proper draping. You do want to make sure that the patient is covered completely. A provider should know that, but you only expose one part at a time. We make sure that our patients are never just fully exposed. And so some of your responsibilities during the exam may be assisting with positioning, handing instruments to a provider, collecting specimens, documenting, just being there for the patient to provide reassurance and anticipating any needs from the patient and the provider. After the examination, you want to provide any instructions, process any specimens, clean and restock the room, schedule any follow-up appointments. This is a big part of what a medical assistant does traditionally, especially in a physician office. Okay, so let's talk about some of the measurements that you may take, starting with anthropometric measurements. That is your height and weight, or your body measurements. We need height and weight for multiple things. It can assist in diagnosis, help track growth and development, which is really important for pediatrics. It can assist in the course of treatment, which also includes medication dosages. Some medications are dosed based off of the patient's weight. And it is a meaningful use requirement. Meaningful use is a standard set forth by the Centers of Medicare and Medicaid Services, or CMS, that offers financial benefit and incentives for providers who document these things in their electronic record. Okay, so the procedure for performing height and weight, which of course is one of our skills that we check off on in the course. You want to make sure that you have your correct equipment. You calibrate your scale depending on the type of scale you use. I would say nowadays most places use a digital scale, but if you had one that had the different weight scales, the beam scale, you would want to make sure that that was calibrated the correct way. Ask the patient to remove any shoes or any heavy clothing. If they refuse or they decline to remove their shoes, that is okay. You would just have them weigh anyway and document that that was there, and document and let the provider know. Same thing as if they refuse to have their weight done at all. You can absolutely just say okay, and let the provider know and let them handle that. Height is especially important for a first visit, a lot of times for annual exams, but most times you don't do a height every visit, except or unless they're a pediatric patient. Weight, however, is typically done at every visit, again, for the reasons that I've already said. And then having both height and weight together helps you calculate BMI. So BMI stands for body mass index. It is crucial for evaluating body fat in relation to height and weight. It is calculated by dividing weight in kilograms. And so in order to get weight in pounds to kilograms, is you would divide the weight in pounds, you would divide that by 2.2. And that will give you your weight in kilograms. And then you can see the formula there on how you would calculate it. I would say that most electronic records now, when you put the height and the weight in the computer, it automatically populates their BMI. And then based off that BMI is their weight status, and then it puts it in different categories. So below 18.5 would be considered underweight. A normal weight or healthy weight is 18.5 to 24.9. Overweight is 25 to 29.9. And then they categorize obesity in class 1, 2, and 3. So anything over a BMI over 30 is considered obesity. Class 1 is up until 35. Class 2 is 35 to 40. And then class 3 is anything above 40. Okay, so pediatric measurements. We will actually discuss pediatrics some more later on in the course, but I'm going to give you just kind of a quick run through as it relates to vital signs and measurements that you need to be aware of when it comes to pediatrics. So for pediatrics, they are all of their medications are dosed based on weight. So you have to have a correct weight, and it's typically in kilograms. Also, their growth and how they grow is monitored, and that will help to detect any abnormalities and make sure that they have correct nutritional status. It's really important to have correct anthropometric measurements for pediatrics. So that includes height, weight, and then also head circumference. Typically, this says to 36 months. I think NHA says 2-3 years. Is that correct? Is that 3 years? Mm, yes, it is. Okay. So 2-3 years. It was throwing me off 36 months. Um, so you would assess head circumference. And the reason they assess head circumference is for things called microcephaly, which is an underdeveloped brain, and macrocephaly, which is in an abnormally large head, which can be from intracranial pressure, or hydrocephalus, which is fluid on the brain. Neither of those are a good thing and will need to be treated immediately. Let's see. All right, so here's growth charts. Growth charts are, again, vital for monitoring child development. Average is about 50th percentile. And when they do these growth charts, they do this by age and by sex, so male and female, and then based off their age. And then it gives you sort of a graph or a chart. Um, and 50th percentile would be what we call average. Um, Others close to that are fine. What we worry about is when it is below the 3rd percentile or above the 97th percentile, which can mean something significant as far as a health related issue. I will say, I think most growth charts are through the CDC, but there are also the WHO growth charts to 2 years, up to 2 years. CDC is 2 to 20. Measuring infants. For infants or children who can't stand yet, we get length. I want to be clear that you pay attention to that because that is a question frequently. How do you obtain length versus height? Or you'll see something like that. Height is when the person is standing and you're getting it from a height scale. Length, they're laying down in supine position, meaning on their back. And we're getting the length from their head to the heel of their foot. And so that's typically for infants and babies. They typically undress the infant down to a diaper or take the diaper off and change it. Obviously, completely undressed would be the most accurate way. Measuring the length, there's a couple of ways that this is done. There are actually infant scales that have the length strip on it that you can measure it to. Some will mark the top of their head and the bottom of their foot on the paper, the table paper, and then measure that. And some will measure with the measuring tape from their head to the heel of their foot. It is important that these are done accurately so that it can be documented appropriately and put on the growth chart appropriately. So as a medical assistant, some of your responsibilities would be, if you're working in pediatrics, before the exam, making sure you're getting an accurate patient history from their caregiver. Use age-appropriate toys as distractions. Make sure you're speaking to the patient in the age-appropriate way. During the exam, assist the provider, offer comfort for the child. After the exam, you, as the medical assistant, can administer any immunizations or injections, schedule follow-ups, and document, of course, all those procedures. Again, we'll talk about some of this more in another chapter, but one of the main things that happens in pediatric visits are vaccines. And so those are on a particular schedule set forth by the CDC that children of certain age get vaccines. Some of the reasons why you would need to make sure they're rescheduled for a vaccine appointment is if they had an allergic reaction to the previous dose, have an allergy to the vaccine or the vaccine component, have had encephalopathy, they're in an immunocompromised state. Those are some of the reasons why we wouldn't. They have moderate or severe acute illness, fever, that kind of thing. And then anytime a vaccine is given, it is required that they get that the patient and or caregiver gets the vaccine information statement, which is a VIS. And so that is, if you've ever had a vaccine or known anybody that's had a vaccine, even if it's just your flu shot, they have to give you that printout of that piece of paper that says everything about that particular vaccine. And then as the medical assistant, you would have to document that that was given and who that was given to, as well as the most recent date on that VIS. These are some of the common vaccines by age: birth, hepatitis B, 2 months, DTaP, which is diphtheria, tetanus, and pertussis, Hib, Hep B, a second dose, 4 months, 6 months, 12 to 15 months. This one's important. I have seen NHA ask this question a few times, specifically at what age does the CDC recommend an MMR, which is measles, mumps, and rubella? That is between 12 to 15 months of age, as well as varicella, which is chickenpox. And then 11 to 12 years, they can get Tdap, which is tetanus, diphtheria, and pertussis. So those are just some of the vaccines. Again, we'll talk about this a little more later, but pay close attention to the MMR vaccine, because that's the one I've seen them ask about. Temperature. Okay, let's get into our vital signs. TPRBP is what I like to say. That's how we document vital signs: temperature, pulse, respiration, and then blood pressure. So temperature, the reason I guess here's your definition of temperature: the relationship between heat production and heat loss in the body. And the reason we measure a temperature is to assess for fever. Or pyrexia, which is the medical term for fever. Fever is the body's natural defense to fight off invasive organisms. It is a normal reaction to illness. It's actually a good thing. It means your body or your immune system is fighting off whatever infection or illness is there. And it is a critical vital sign. So questions to ask before taking oral temperature. Again, in my classroom, we check off using an oral thermometer. So some of the things you want to ask before you take that is, have you had anything hot or cold to eat or drink in the last 15 minutes? Because if they just drank something really cold, their temperature might be lower. Hot, it might be higher. And we don't want to make a treatment plan based off of that. Have they smoked recently or exercised, again, in the last 15 minutes, because that can alter their temperature as well. So there are different methods. I would say probably the most common is oral temperature. That is holding that thermometer probe under the tongue with the mouth closed. This is not easy to do for children, and obviously you can't do that on unconscious patients. Another method to do for children would be an axillary temperature. The med-term axillary means armpit. And so it is less accurate, but it is easier to do and not invasive. However, it does take longer. The next one would be tympanic. Your tympanic membrane is your eardrum. So this is done in the ear. If the patient is under 3 years old, you would want to hold the pinna, or the the outer part of your ear. You want to hold that down, or almost the earlobe. Hold it down and back if they're under 3 years old. If they're over 3 years old, then you would want to hold the ear up and back to open up the ear canal. We do not do a tympanic temperature on anyone who is suspected of having an ear infection or has excessive cerumen. Cerumen is earwax. Another form of temperature measurement could be temporal. That is across the forehead and over the temporal artery, which is on the side of the forehead. It is non-invasive. It's well tolerated. However, the accuracy can be affected by sweating, sunlight. So it's, again, not the most accurate, but easy to do. And then the last method that we would use, because it is the most invasive, would be a rectal temperature. It is the most accurate, but it can potentially cause some issues if it's not done correctly. You use it frequently for infants and unconscious patients, and if you need it to be really accurate. So some of those temperature ranges may be different based off the site. So, for instance, rectal temperature is the most accurate. It's representing core body temperature. So it tends to be about a half degree to 1 full degree higher than what an oral temperature would be. Whereas axillary temperature is less accurate, so it tends to be a half degree to a 1 degree lower than oral body temperature. So I was taught, and NHA does not say this, but I was taught that if you take an axillary temperature, you add a degree to it. So if you took an axillary temperature and you got 96, you would actually document 97. Again, NHA does not say that. And so for testing purposes, I would not say you have to know that, but make sure you follow your facility protocol. There are some formulas here for converting Fahrenheit to Celsius. Thankfully, most thermometers these days do that for you. But that is the conversion formula there. And NHA does like to throw those formulas in there sometimes. There is no calculator on the exam, so they say that they're not going to ask you to do any type of math that would require a calculator. So it may be something along the lines of just identifying the formula versus actually calculating it on your own. Normal temperature ranges by age. So for an adult, the normal range is between 97 to 99, with the average body temperature being 98.6 degrees Fahrenheit. 98.6 degrees Fahrenheit is the equivalent of 37 degrees Celsius. You need to make sure you know that. There are so many NHA style questions that ask about average body temperature. So I'm going to say it again. Average body temperature is 98.6 degrees Fahrenheit and 37 degrees Celsius. Make sure you wrote that down. And then there are some changes based off age here. Newborns and 1-year-olds have a higher body temperature, whereas over 70, elderly patients tend to have a lower baseline temperature due to decreased metabolism. So you want to make sure that you are aware of those bodily changes as you're assessing temperature. Moving on to pulse. Pulse, also known as heart rate, is the wave of blood that flows through the arteries with each heartbeat. So arteries blood travels away from the heart through your arteries. And so that is why there's a lot of pressure at pulse points, because your heart requires a lot of pressure to push the blood away from it and to the places it needs to go in the body. And so that's why we use arteries to evaluate pulse. So there are multiple pulse sites in your body. There is your temporal pulse, and that is at your temple, which is in front of the ear, kind of at your head. A lot of people will say they have a headache. It's kind of right there, and they can feel it pulsating. Carotid is at your neck. That is what we use for CPR assessment. Brachial is in the inner aspect of the elbow. In the inner aspect of the biceps at the elbow. It is what we use for blood pressure measurement, and also what we do for an infant for CPR. Radial runs along your radius bone in your on the thumb side of your arm, and it's right there in the wrist. That is what we use most routinely for just a routine pulse assessment. Other sites include the femoral artery, which is in your groin, used a lot of times in emergencies, or that's actually where they enter to do a lot of heart caths. Popliteal is behind the knee. Posterior tibial is behind the ankle. And dorsalis pedis, or your pedal pulse, is on the top of the foot. And that, of course, is assessing circulation to your lower extremities, but all the popliteal, posterior tibial, and dorsalis pedis. So we're going to talk about how to assess pulse rate based on the radial pulse there at the wrist. So again, it's on the thumb side of the wrist. So you'll position the patient either laying down or sitting. You will put your fingers kind of in the groove of the thumb side of the wrist, push down and then up until you feel the pulsation at their wrist. And you would count that every beat for 30 seconds and multiply that times 2, or for a full 60 seconds to get how many beats per minute. For an apical pulse, this is measured with a stethoscope. So this is auscultated, meaning you're listening to the heartbeats. This is, of course, frequently done on children and infants and anyone who has an irregular rhythm. So you would place the stethoscope at the apex of the heart, which is the bottom part of the heart, at the fifth intercostal space, mid-clavicular line, and then you would count that for a full 60 seconds. The pulse changes based off age. For an adolescent or older, a normal pulse rate is 60 to 100 beats per minute. That is your average pulse rate or heart rate. And it is higher if you're younger than that. So newborns and infants, theirs can be anywhere from 80 to 160. Typically, they're in the 100s, and that's normal for them. So pulse gets lower as you age. Moving on to respiration. So after pulse is respiration. Respiration is the process of breathing that includes one breath in or inhalation and one breath out, exhalation. And that is considered one respiration. When we measure respirations, we try to do it without letting the patient know, so that they are not aware and they don't change the way they breathe. And we observe their chest rise and fall for 1 full minute or 30 seconds and multiply that times 2. Respiratory rate is similar to pulse. Newborns and infants breathe about 30 to 60 times per minute. And as you age, it gets lower, just like with pulse. Both pulse and respiration get lower as you age. And so for an adult or adolescent and older, a normal respiratory rate is between 12 to 20 breaths per minute. And again, if you're breathing really slow, that would be bradyapnea. So it would be less than 12. If you are breathing really fast, that would be above 20 breaths per minute, and that would be called tachypnea, which is not listed here, but here are some other abnormal breathing. Dyspnea is difficult or labored breathing. You're having trouble breathing. Orthopnea, that's trouble or difficulty breathing when you're laying flat. That's common in people with heart failure, COPD, and pregnant women can't lay flat or they have trouble breathing. Hyperventilation, of course. And then there are abnormal breath sounds. Again, most assessments, like listening to breath sounds, are done by the nurse or the provider. But as a medical assistant, if you hear some of these abnormal breath sounds, like wheezing, which is high-pitched whistling sounds, sometimes that can be heard, just audibly heard without even listening with a stethoscope. Rails or crackles is the other, and that means there's fluid in the airway. And then rhonchi is these low-pitched, like snoring sounds, very common in people with COPD. And then the last vital sign we talk about, and probably one of the most important, is blood pressure. It indicates the force of circulating blood on the walls of the arteries. It is measured with systolic blood pressure, and systole is when your heart contracts. So that's systolic pressure. So that's your top number. That's when your heart beats or pushes the blood out to the body. And then there's a bottom number called the diastolic pressure, is when your heart is at rest or relaxes, when it fills back up with blood, which is why your top number is typically always higher than the bottom number. And that's supposed to be that way because the pressure should be higher when your heart pushes blood out to the body versus when it is at rest and filling back up with that blood. So how we measure blood pressure, there are automated blood pressure cuffs like the one in this picture. That is, you put it on the arm and you press start or however you use the equipment. If we're going to do a manual blood pressure, we're going to need a sphygmomanometer, which is the little, it's not the cuff. There's also a cuff, and it's just the little piece that's on there that I can't think of the word of, and a stethoscope, because we are going to auscultate blood pressure, meaning we're going to listen to it. As we're listening to blood pressure, we listen for the carot cough sounds. These are the sounds that are heard during blood pressure measurement. The first sound, or phase one, is the first clear tapping sound. So that's your top number. The first clear tapping sound you hear would be your top number. And then it goes into some soft swishing sounds, and then you get into a sharper, like bump, 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 like that. That's phase three. Phase four is sort of a muffling sound until phase five happens, and that sound disappears. Once that sound disappears completely, that is what is documented as your diastolic blood pressure. And this is the steps, step by one. Sorry, one by one. It is really important as you're taking a manual blood pressure or even using the electronic blood pressure cuff that your patient is positioned correctly. They should be seated, feet flat on the ground, with their arm at heart level, not above their head, below their body. Their legs should not be crossed. They should have rested for at least 5 minutes. They haven't smoked, exercised right before they came in, or else you'll have to have them sit there for about 15 minutes, because all of those things can affect getting an accurate result. Correct cuff size is also important. If you have a cuff too big, you're going to get the wrong blood pressure. It'll be lower than it's supposed to be. If you have a cuff too small, it's going to be higher than it's supposed to be. And then, of course, we want to make sure it's on in the right place. One of the things that you have to do is determine how high to pump up that the bulb on the blood pressure cuff. And you can do that by estimating the systolic blood pressure, or estimating the top number with the palpation method. How you do that is you find the radial pulse after you put the cuff on the arm. Once you feel it, then you pump up the cuff, or pump up the bulb, pump up the cuff, that's correct, until you can no longer feel the radial pulse. Whatever that number is should be your estimated systolic blood pressure. That just helps you miss, the oscillatory gap. That is really difficult to do and not, and it's difficult also to teach students to do. So my recommendation for real world practice is always ask the patient what their typical blood pressure is. If they say they don't know, you can look at their chart. If they're brand new, then you can do this estimated pressure, the palpation method. But if they say, oh, my blood pressure is always 100 on the top, I'm not going to pump it up to 200. Okay. That's too much. Typically, it's about 30 millimeters of mercury over what they say is about what I recommend. So if they say it's normally 200 on the top, I'm going to go to about 230. Just in hopes that I'm not missing that first sound. If I think that I did, you can deflate it, give the arm some time to rest, and do it again and pump it up a little bit higher. When we put the stethoscope on the patient's arm, we put that over the brachial artery. And then once the cuff is pumped up 30 millimeters above the systolic pressure, we're going to slowly deflate, not too fast, but slowly, until we hear the first sound. And then once we hear the last sound, we can deflate it. That first sound we hear is the top number. That last sound is the bottom number. Some things, or some common errors in blood pressure measurement: using the wrong cuff, which I've already talked about. Improper positioning is probably the most common. Talking, your patient cannot talk while you're taking their blood pressure, so don't ask them questions, because it will affect the blood pressure reading. If they just ran, if they just had a bunch of caffeine, if they just smoked, if the room's cold and they're shivering, it can make your blood pressure. If they're upset, if they're crying and like hyperventilating, we're not going to check their blood pressure right then. It won't be accurate. So those are just some, and rapid deflating the cuff too quickly. That can affect um, a correct reading. Some contraindication for which arm to use. I always tell my students to make sure you ask your patient, do you have a preference for which arm I use? Because if they have one of these things that's contraindicated, they typically tell you, oh, I can't use this arm because of this. I have to use this arm. So just always ask. Um, some of the reasons that it may be contraindicated: mastectomies, which is removal of a breast, most often related to breast cancer. Oftentimes, they'll have either only one breast removed, and we would not use that arm on that side, or if they had both, one's typically a radical mastectomy and one's a simple mastectomy, meaning the side that had the breast cancer in it, they probably also removed a lymph node on that side. And whatever side that is the side we will not do blood pressure on because it could potentially cause lymphedema or swelling in that arm. We don't do blood pressure on the arm that has a dialysis shunt because it can damage it. Any IV lines, because again, it can also occlude it and damage it. Any injuries, like if they have a cast, a fracture, a severe wound or burn, anything like that, we would not use that arm. Blood pressure stages. So, unlike pulse and respiration, when you're talking about blood pressure per age, with pulse and respiration, as you age, those numbers get lower, whereas as you age, blood pressure gets higher. So infants and newborns' blood pressure are typically lower than what a normal is for an adult. Normal for adults would be less than 120/80. I want to be very specific here because for the longest time, everyone said 120/80 was considered normal. That is not correct. 120/80 is now considered pre-hypertension. So in order for it to be normal, your systolic pressure has to be less than 120 and your diastolic pressure has to be less than 80. Pre-hypertension is up until 130/80. Stage 1 is anywhere from up until 140/90. Stage 2 is 140/90 or above. Hypertensive crisis. Hypertensive crisis would be anything over 180/120, and that is a medical emergency. It requires immediate medical attention because of the risk for stroke, especially. Pulse oximetry measures oxygen saturation in the blood. Well, that's the percentage of hemoglobin in the blood. It is read as SpO2. Normal readings would be 95 to 100% for most individuals, whereas COPD patients, which is chronic obstructive pulmonary disorders, significant chronic respiratory disorders, their normal may be between 88 to 92%. And while that's not good, that's just what their normal is. There are some things that could affect getting an accurate reading for pulse oximetry. In order to do that, we put a little probe over the finger. And if they don't have good circulation to that finger, if that finger is really cold, if they have artificial nails or dark nail polish, severe anemia, some of those things, you may not get an accurate reading. And then, of course, we'll want to, troubleshoot those things like removing nail polish, warming the extremity. Those are some things we can do to try to troubleshoot that and get an accurate reading. Here is your lecture question. What to think about. Imagine a 45-year-old patient comes in with these numbers: temperature of 101.8 Fahrenheit orally, pulse 110 beats per minute, breathing 24 breaths per minute, and blood pressure of 95/60 millimeters of mercury. This patient also says they feel dizzy when they stand up, have had flu-like symptoms for 3 days. So, based on these facts, what do you think is happening with this patient, and what other checks should you do, and what safety steps should you take? So, think about that, what those vital sign measurements mean, and what the patient's complaints mean for that patient, and what you would do based off that. Orthostatic hypotension assessment. Orthostatic hypotension is when there's an abnormal drop in blood pressure when you're changing position. So typically from laying down to standing up, it causes dizziness and fainting because the blood pressure drops so low. And so if we are assessing for orthostatic hypotension, you would have to measure the blood pressure while the patient is lying down in supine position, have the patient sit up and check the blood pressure then, and then have the patient stand up and check their blood pressure, and document all of these readings. A drop of more than 20 millimeters per mercury in the systolic blood pressure, or more than 10 in the diastolic within 3 minutes, would be a positive finding for orthostatic hypotension. Common causes are dehydration, blood loss, medications, prolonged bed rest, advanced age. This is really common in the elderly. And so once you have completed all of these things, you would want to document, record all of these vital signs with date, time, and your initials. Most of the time, electronic records will time and date for you, and you'll be under your own settings, so it'll have your own information. But we do want to make sure we document what position they were in, what arm we used, what temperature site, because again, these things change based off which method you use. If there were any abnormal findings, we want to make sure we let the provider know, and even check to see for any trending. So look at previous vital signs and compare to what you got. And then, of course, patient education about what these different vital signs mean, if it's abnormal, and what that could mean for them. And then we, of course, want to document all of this correctly. So some important takeaways from this unit. Patient intake and vital signs are primary jobs of medical assistants. So understanding how to do this and how to do these all correctly is really important. So getting a thorough screening and collection of history and patient care is crucial to the appointment and what happens. Taking correct vital signs like temperature, pulse, respiration, and blood pressure is vital. And then, of course, knowing the normal ranges, because the very first thing they're going to ask you, especially blood pressure, when you take a blood pressure is that normal? And we're not going to make up things for patients. We're not going to lie to them. We're going to let them know if it's normal or not. And in order for you to do that, you have to know if it's normal or not. So it should be a priority that you know what normal vital signs are, what those ranges are. And then, of course, we want to document accurately and promptly report anything that's abnormal to the provider.